To everyone under the sound of my voice, I bid you welcome wherever you may find yourself. I just need to talk to you for a few moments before we bring on the good doctor. You know, there's a gentleman, Chief Tecumseh, Cheyenne Chief, used to promote resisting the government from taking over Native American land. And he wrote a poem. I'm going to read the first paragraph for you. So live your life. This is his poem. So live your life that the fear of death can never enter your heart. Trouble no one about their religion, respect others in their view, and demand that they respect your love your life, perfect your life, beautify all things in your life. Seek to make your life along and its purpose in the service of people. And listen to this last sentence. Always show respect to all people and grovel to no one. Hmm? Here we go, ladies and gentlemen. That's the preamble to Black Life Does Matter. I don't care what nobody tell you. Jim Crow is on its way. We need to be ready for it. The Kansas Seventh-day Adventist Church sponsors this program, and it has a theme for 2022, greater than. The supporting scripture is Philippians 4:13, and it says, I can do all things through Christ who strengthens me. And Matthew 19:26, with man, this is impossible, but with God, say it with me, all things are possible. The title of today's program is Colorectal Cancer. In a moment, she will explain to you what that means. In the meantime, Dr. Youngberg, in his book, Hello Healthy, page 9, he says, you and I must be the one in charge of our personal health. Your personal physician can't do it for you. No one can do it except you. End of quote. Pray with me. Our Father and our God, we come to you this morning and we present Dr. Denise Jackson Townsend. Lord, bless her with recollection. Bless her with the information that she's going to share with this entire world. And may after this, your name be glorified and we are healthy because of it. In Jesus' name we pray. Amen. Ladies and gentlemen, this program was created by Dr. Ainsworth Keith Morris, Dr. Jenkins, and Pastor McBride, and they did a fantastic job. The ministry, health ministry, is led by Nirma Usher and our awesome team. So when you see them, say hello to them. Today, Dr. Denise Jackson Townsend is our presenter on colorectal cancer. And hey, Doc, before I let you go, I just need to read something here. I feel like I'm a part of this family. So, Dr. Denise Townsend is a physician specializing in internal medicine. She obtained her medical degree from the University of Florida in Gainesville, Florida. And if you see me jumping around, it's because I'm excited. She then completed her internship and residency in internal medicine at Loma Linda University Medical Center, my alma mater. Here we go. She's currently on the faculty of Loma Linda University School of Medicine, in the role of teaching medical student and residency during their internal medicine rotation. She's also one of the associate professor, program director for the internal medicine residency program, Loma Linda University Health System. She's also a hospitalist at the Loma Linda VA Hospital. She's married to Michael Townsend. Hi, Michael. And they are proud parents of 3 adult daughters. You saw one of them. All right, here we go. Dr. Townsend, welcome. You look great.
Thank you. Happy to be here this morning.
All right. So listen, Doc, I'm going to just read one of the questions. I'll let you go, and then we'll come back and get in the Q&A. One of the questions says, what is colon health? And is the rectum part of colon health? I see you on the other side of your presentation.
Okay. All right. So I will be answering that question as we go along through our presentation. So starting off with colon health and cancer screening, I want to talk about the colon. So the colon is part of the digestive system. So as we eat, food enters our mouth, goes down our esophagus to our stomach, then it travels into the small intestines, and then finally into the large intestines or the colon. And the colon, as you see here, is divided into 5 parts. There is the cecum and the ascending colon, which is considered part of the proximal or the right side of the colon. Then you have the transverse colon. Then you have the descending colon, sigmoid colon, which are considered part of the left side of the colon or the distal colon, and the rectum, which is also part of our presentation. So I said colon cancer, but it's actually colorectal cancer is how we consider it. And it's kind of treated together, though there are some differences in how one would treat rectal cancer as well, too. So the colon is 5 feet long, approximately, and the transit time through the colon can be from 30 to about 42 hours, though up to 72 hours in some people can also be normal. Transit time is shorter in men than in women. Now, the colon basically has a main function of handling our indigestible food material. So it does this in 4 main ways, and it reabsorbs water and other substances such as sodium, potassium, and chloride. It also temporarily it forms and temporarily stores feces until we can excrete them. It is a reservoir for bacteria, particularly our gut microbiome, which is sort of a hot area right now. A lot of research going on, figuring out how the bacteria in our gut can be helpful and harmful. But our gut microbiome ferments our indigestible material, converting some of it into short chain fatty acids, which works as food for other parts of the bacteria. It releases methane gas, and it also can interact with our immune system. So I'm going to briefly just go over some of the common disorders of the colon. Constipation is being one of those that I think most of us have experienced in some way in our lives. And so constipation is defined as being less than 3 bowel movements per week, or stools that are very hard, stools that are hard to pass, and that you might feel as though you have incompletely emptied your colon once you have passed them. So the causes for constipation are there are many causes. So such as dehydration is one, low fiber diet, being physically inactive, having travel or alterations in your usual schedule, some medications such as narcotics, and also medical conditions such as low functioning thyroids or hypothyroidism. So the treatment for those are basically addressing those issues, such as increasing your fluid intake, being sure that you have adequate amounts of water each day, increasing more fiber in your diet, particularly fiber from whole grains, legumes, fruits and vegetables, physical activity, being sure that you have a regular schedule. Our body's strongest urge to defecate is right after breakfast in the morning. So if it's possible, that's a great time to set aside some time to just spend some time in the bathroom with a good elimination. And also treating underlying conditions such as low functioning thyroid, other conditions that might increase calcium in your system. Treating those, having your physician help you treat those, would be ways to work on constipation, and adjusting your medications if it seems that that's the cause of the constipation. Now, another thing that we talked about is diverticulosis. So often patients will have, say, a colonoscopy or procedure, and they'll be told, oh, you have diverticulosis. And they'll wonder, what is a diverticulosis? Well, diverticulosis basically is a pouch or in the weak areas of the wall of the colon wall. And if you were to look at the colon through a scope, what you would see would be these little round circles, which are the openings to the diverticuli. Now, the diverticulosis has a higher incidence in our Western culture, and this has to do with the fact that we tend to have less fiber in our diets versus other parts of the world. It is more common at over the age of 60. One important thing about it is that they do not become cancer. However, they mostly have no symptoms, but sometimes they can bleed. Sometimes they can become infected, and that's called diverticulitis when they become infected. And sometimes they can perforate, which means they rupture or develop holes in them. And of course, if that were to happen, you would be in the hospital. You'd have antibiotics and other treatment for it. But for the most part, they don't cause any problems to people. And certainly, being sure to add more fiber to your diet is one way of preventing them, not treating them. You can't really treat them once they occur, but prevention would be having fiber in your diet. Now, the next condition is called irritable bowel syndrome. And actually, it is not a disease. It is actually a collection of symptoms. The symptoms would be abdominal pain and also changes in stool consistency. So these symptoms would occur more than 3 times per month. And there's divided into things such as irritable bowel with diarrhea, irritable bowel with constipation, irritable bowel syndrome with alternating bouts of diarrhea and constipation. And we're not really sure what really causes it, but we think it can be associated with stress and other conditions such as fibromyalgia may be one that might also be associated with irritable bowel syndrome. So the treatment is basically just kind of seeing if you can decrease stress and deal with some of the other conditions that it might be associated with. There are medications that are specifically designed to treat the constipation associated with irritable bowel diarrhea, and adding fiber to your diet can also be helpful. The next condition we'll talk about is inflammatory bowel disease. Now, inflammatory bowel disease is an autoimmune condition or autoimmune conditions such as ulcerative colitis or Crohn's disease. And symptoms can be abdominal pain, bloody diarrhea, fever, weight loss. Crohn's disease can occur anywhere in the digestive system. Ulcerative colitis is usually limited to the colon itself. A treatment, there are various medicines used to treat them, particularly ulcerative colitis, such as mesalamine or steroids, particularly in the form of enemas or sulfasalazine. And so your provider would be the one to really help you to treat your inflammatory bowel disease. And then enterocolitis. And so we think of this in terms of things like infections, such as stomach flu, traveler's diarrhea, or else C. diff refers to Clostridium difficile, which is an infection which can occur as a result of long-term treatment with antibiotics. There are some other causes as well that are non-infectious, but the treatment depends on the offending, particularly if it's infectious, depends on the offending agent and the severity of it. Some infections don't require any in treatment as such, they kind of run their course. Others may require some antibiotics. Some can be treated as an outpatient, and some, depending on the severity, may require inpatient admission and treatment. Now, the next thing we'll talk about are colon polyps. So colon polyps basically are excess tissue which grows in the inside lining of the colon. So the colon is really like an empty tube or a hollow tube, and it has several layers to it. And so the mucosa is the lining of the inside of the actual colon. And that's where the polyps will grow off from that. And then there are several different types of polyps. So there's some called hyperplastic, which are simply extra tissue that grows. And there's a very low risk of cancer from these. Then there are different polyps called sessile serrated polyps. And some of these, sessile meaning flat, so they can be a little bit more difficult to see when you look into the colon because they are flat. Serrated refers to the difference in histology, and there's a variable amount of cancer potential from these kinds of polyps. Some of them are like hyperplastic, which is has a very low cancer risk, and some have a little higher cancer risk. Then the most common that we see are called adenomatous or tubular. 70% of polyps are of this type, and a small percentage of these, about 5 to 10%, can transform into cancer. And then you have Villus adenomas, or they may even be called tubulovillus adenomas, depending on their histology or the what you see on pathology when you look under a microscope. And these can transform into cancer and do require or can require more frequent screening. Now, this is just a picture of what a colon cancer might look like. Now, colon cancer. So, cells that line the inside colon wall can grow rapidly and abnormally. They can be influenced by toxins and um, cancer-causing agents, which are traveling through our colon in the fecal material. That's why I think it's very important to try to maintain a good elimination habit and decrease the risk for constipation, because the less these toxins are in contact with your colon wall, the less the chance of having them affect the cells of the colon wall, making them transform into cancer cells. Colon cancer generally arises from polyps. It is the third most common cause of cancer among both men and women in the United States, behind prostate and lung for men and behind breast and lung for women. Occurs approximately 25% more frequently in men than in women. In the US, African Americans have approximately a 25% higher risk of CRC, which is my short term for colorectal cancer, than white Americans. And our mortality can be anywhere from 20 to 40% higher. When it does occur in African Americans, it usually occurs at a younger age, can occur more proximal. That's the right side of the colon, if you recall the cecum and the ascending colon, and can be diagnosed at a more advanced stage. And as an example of that, I want to remind you of one of our actors named Chadwick Boseman, who is probably best known for his role as Black Panther in that movie. And he was diagnosed with colon cancer at approximately 39. At stage 3, he battled it for about 4 years and succumbed at the age of 43. So sad loss for us, sad loss of a young man at the pinnacle of his career to colon cancer. Now, risk factors are divided into modifiable and non-modifiable. So things you can change and things you can't change. One is if older age, so over age 50 is usually what we consider as being a risk factor. However, there has been a rise in colon cancer in groups from age 40 to 49, so that we have modified our recommendations for screening. We used to say over the age of 50, you wanted to screen for colon cancer. We have now decreased that age to 45 because of this. So other non-modifiable risk factors would be a personal history of colon polyps, or a personal history of inflammatory bowel disease, such as ulcerative colitis or Crohn's that we talked about earlier. If you have a family history, particularly a first-degree relative, such as a parent, a sibling, or a child with colon polyps or cancer, or if they have other cancers such as ovarian, endometrial, or breast cancer, these can be non-modifiable risk factors for colon cancer. And then there are some genetic diseases which are rare, such as Lynch syndrome and familial adenomatous polyposis. These are conditions where the body forms more polyps. So those are non-modifiable things you can't do anything about. But now there is a list of modifiable ones. And so look at this list. We have a lot of things we can do here. So if we're overweight or obese, that's a risk factor. Being physically inactive is also a risk factor. Smoking cigarettes, a risk factor. Excessive alcohol use. Our diet's a big one. Diets that are high in red or processed meats or charred meats, that means barbecue. A diet that is low in fruits and vegetables and fiber can be risk factors. Diabetes mellitus in some studies can be a risk factor, and low vitamin D levels. I put a question mark here because there can be some controversy there, but it seems that in most of the studies that I've looked at, the data seems to suggest, particularly if one has been diagnosed with early stage colon cancer, that the use of vitamin D supplementation, if your vitamin D levels have been measured and are low, can be helpful or beneficial. Now, what are symptoms of colon cancer? So the first few symptoms are ones that are more specifically for colon cancer. So changes in bowel habits, such as having diarrhea or constipation, or thin stools. We usually say pencil thin stools for more than a few days. Also, if you have a persistent urge to have a bowel movement and after passing your stool, you still feel like that, having blood in your stool, having been diagnosed with low blood counts or anemia. Those are some that are kind of pretty specific for colon cancer. Other more generalized symptoms, abdominal pain, cramping, bloating, or feeling full, weakness and fatigue, unintentional weight loss, and nausea or vomiting. So, a lot of these symptoms, particularly the last four, can occur with other conditions. So, it's very important that if you're having any of these symptoms, that you should seek the attention and the care of your health provider. The diagnosis of colon cancer is usually made with doing a colonoscopy, and I'll describe that procedure in a few minutes, and then with a biopsy. And then for staging, in order to find out if it's limited to just the colon or if it's spread to other parts of the body, they would do a CT scan or PET scan. So, when we talk about stages of colorectal cancer, stage 0 would be just finding sort of a precancerous polyp, one that's not spread beyond the inner lining of the colon or rectum. Stage 2 would be where it had spread into the colon or rectum, but has not spread to nearby lymph nodes or other organs. That's stage 1. Stage 2 would be cancer has grown into the outermost layers of the colon or rectum. Remember, we talked about the colon having several different layers. So now it will have grown through the layers of the colon or rectum and may be attaching to nearby organs, but hasn't spread to lymph nodes yet. Stage 3 is where it spreads to nearby lymph nodes, but not distant parts of the body. And stage 4 is where it has spread to distant organs, such as liver, lung, peritoneum. And these are the areas that colon cancer likes to spread to, or we call that metastasize to. So how do we treat colorectal cancer? And this is just very, very generalized. If one is diagnosed with colorectal cancer, it's very important to work with your provider to set up an individualized treatment program for you. But in general, it's treated with surgery. If you have a stage 0 to 1, very slight early stage colorectal cancer, sometimes removing just the polyp it's in, particularly if the base of the stalk of the polyp is free of cancer, that may be good enough. If it's progressed beyond that, a surgery to remove the part of the colon where the cancer has spread would be advised. For early stages, and then also chemotherapy, which is medications that kill or stop tumor cells from growing, would be part of it. And radiation therapy can be part of treatment for rectal cancer, not so much for colon, but for rectal. If you're diagnosed with stage 4, often they may not recommend surgery as such and more chemo, but sometimes they will recommend surgery to remove, maybe if they have just some very localized spots where it has metastasized to. So let's talk about screening for colon cancer. So there are several tools or methods that we have for screening. The first one, and which we call our gold standard, by that we mean this is the most common, this is the most tried and true system, and it's the one by which all other screening methods are measured, is called colonoscopy. So colonoscopy is a procedure where a long flexible tube that has a light on the end is used, and it actually allows the operator to be able to see inside the colon. So it is inserted into the anus and then passed along and moved through the colon all the way to the cecum. And that's a good evaluation. If the physician is unable to get to the cecum, then that's considered an incomplete exam. And the cecum being the very first part of the colon. So once they have inserted it all the way to the cecum, then they slowly withdraw it. And while they're withdrawing the scope, they're looking at the lining of the colon to see if there are polyps or cancer. Patients are usually sedated. Generally, the only time we don't sedate someone is if someone requests not to be sedated. But generally, you're sedated usually with a Valium-like medication like Versed, or a narcotic, so you're not aware of the procedure. So the advantages of this procedure is that it allows direct visualization of the lining of the colon, and it allows them to remove a polyp or biopsy it right at that same time. The disadvantages would be that it is somewhat invasive, that you have to be sedated for it. That means you have to go to a certain suite and you have to have someone to drive you home because you'll be sleepy, and it requires a little time to recover from the sedation medication. And this is what I tell patients are the worst, is what I think is the worst part of the whole thing is the prep. So often they will use what's called Go Lightly, which usually requires you to drink about 4 liters of this fluid in about an hour or two, which is kind of difficult. And of course, frequent trips to the restroom. So that's probably the worst part of it. But the good part of it is for at least about 24 hours in time, you know that your colon inside is squeaky clean once you finish the prep. The next procedure would be a flexible sigmoidoscopy. Flexible sigmoidoscopy is the same as colonoscopy. It's just a shorter scope. It only evaluates the left side or the descending side in the sigmoid colon and rectum and anus. Developed because we initially felt that most colon cancers, and probably still most of them, develop on the left side of the colon. But now, since more tumors are being diagnosed on the right side of the colon, it's better to have a full colonoscopy exam. The advantages of this, again, is direct visualization. It requires less prep to no prep. It really just usually you just use a fleet enema. If anything, you don't require any sedation for it. The disadvantages, again, would be that it only looks at the left side, not the right side of the colon, and requires a trip to the doctor's office. It's usually performed, right? It can be performed within the doctor's office. Then the next would be a CT colonoscopy. A CT colonoscopy is a test that uses a CT scan, which is a special kind of X-ray, and it can detect polyps and colorectal cancer as well too. The advantages is that it is not as invasive. The disadvantages would be that it does still require a laxative prep. It does expose you to some radiation, though not any more than a regular X-ray, most likely, or not much more. And if they were to find a polyp or cancer, you would still require a regular colonoscopy to go through and biopsy it. So colonoscopies the studies have found a colonoscopy to be somewhere between 70 to 95% effective at detecting colon cancers and polyps. Flexible sigmoidoscopy is about the same. CT colonoscopy is about 84%. And then the last one would be stool-based tests, such as the FIT test and the FOBT, or fecal occult blood test. Those are tests that are used to detect hemoglobin, which is blood, basically, or a component of blood in the stool itself. And then I put Cologuard down here. That is sort of the one that we're probably most familiar with. It's a test that's used for testing DNA from a polyp or a colon cancer, and it's advertised on television as Cologuard. So these tests, the advantages to them is that they can, the ease of use. So the doctor can give it to you at your office or appointment, or they can mail it to you, and you obtain a small amount of stool at home and you mail it back to your doctor. And so it's very easy. And they have found that patients actually will be more compliant using FIT, particularly because it doesn't require alteration in the diet, and it only requires one sample. And so when we talk about screening, we like to say that whatever a person will screen with is what we really want to go with, though we recommend perhaps colonoscopy as being the best screening test, but with whatever a person will do is what we want to use. Now, these stool-based tests are about 70 to perhaps or estimated to maybe be up to as high as even 95% effective for screening and detecting of polyps and colon cancer. Now, screening frequency. So this is average risk individuals. And so average risk means someone who does not have a family history of polyps or colon cancer, does not have a personal history themselves of polyps, does not have a personal history of inflammatory bowel disease or any of the genetic diseases that put them at risk for frequent polyps. So average risk person, we would recommend a colonoscopy once every 10 years between the ages of 45 to 75. The feeling is if you have a normal colonoscopy, then you probably don't need to use any kind of screening for 10 years, though your doctor may choose to screen you with a stool-based test in between. The sigmoidoscopy we usually recommend every 5 years, CT colonoscopy again every 5 years, and then the stool-based, which is FOBT or Cologuard, would be yearly screening with those. All of these tests screen probably best for left-sided colon lesions than they do for picking up the right, though they can pick up the right as well too. Now for surveillance, now this is generalized information, and again will vary from person to person based on their own circumstances, but it's often based on the type of the polyps found and the number of polyps. So this is surveillance if you've had, say, a colonoscopy and they actually find a polyp. How often do you need to then have repeat colonoscopies? So again, based on the type and the number of the polyps. So if you have sort of an advanced adenoma, that's a polyp that's greater than 10 millimeters in size, that's like 1 centimeter. If it's villus in terms of the type of polyp, you remember we talked about villus before being a higher chance of becoming cancer, or if they have high-grade dysplasia, which means atypical or abnormal cells, then they would recommend that you have another colonoscopy again in 3 years. Now, if you have a colonoscopy and you have an adenoma, which is small, that means less than 10 millimeters, and you have only 1 or 2 of them, then they would say you could probably go between 7 to 10 years for being screening. If you have adenomas where you have 3 to 4 of them and they are small in size, meaning less than 10, you can go between 3 to 5 years. If you have adenomas and you have more than 10 of them, even if they are small, they'll probably suggest in a year that you undergo additional screening. If your provider goes in, finds a polyp and takes it out, what we call piecemeal, meaning just a little piece at a time here and there, then they probably would recommend that you have colonoscopy again in 6 months to be sure that they were able to retrieve all of it. Now, serrated polyps are a little different, and the surveillance is a little different for those as well too, but those are not as common. So I mostly dealt with the adenomas here. And again, your provider would be the one to tell you how often or how soon you need to be screened beyond that. So protective factors. So the protective factors basically are kind of working on those risk factors that are modifiable, such as being physically active, low consumption of alcoholic beverages, avoiding tobacco use, and diet. Here's a big one. So avoiding our or taking a diet that has a low red meat, and by how infrequent would that be? Some sites would recommend maybe no more than 2 to 3 times per week that you have red meat. For processed meat being things like hot dogs, bacon, ham, those kinds of things, luncheon slices, probably very rare for those. And then charred meats, of course, barbecue. So again, limiting yourself to barbecue. This is red meat, not chicken. This refers to red meat. In your diet, you want to have a diet that's high in fruit and vegetable, and then also high in fiber, particularly that found in whole grains. So studies have shown that compared with non-vegetarians, the vegetarian dietary patterns are associated with a significantly reduced risk of colorectal cancer. And one study up to, I think it was the Loma Linda study, showed a decrease of about 45% decreased risk of colorectal cancer. And people who were considered pesca vegetarians actually had the best profile or the lowest risk over even other types of vegetarian diets. There are some conflicting data in regards to other things such as supplements, such as vitamin B6, the use of calcium, magnesium, the use of garlic, the use of vitamin D, fish consumption, and conflicting data on coffee consumption and the use of aspirin. Now, in some sources, they would say that people should use a baby aspirin per day, and anyone for whom an aspirin is not a problem or contraindicated. For example, if you have a history of bleeding from your stomach, you don't want to use aspirin, or bleeding and your doctor's told you not to use aspirin. So there was strong recommendations for using bleeding aspirin, but the most recent, it looks like they're not really sure that aspirin is really protective. So plus minus a baby aspirin a day. So my conclusions then would be, for average risk adults, again, no personal or family history of polyps, colon cancer, no inflammatory bowel disease or genetic conditions, you should start screening at age 45. Depending on what you choose to do, colonoscopy every 10 years, starting at age 45 to 75, CT colonoscopy every 5 years, FlexSig every 5 years, and stool-based tests every 1 year between the ages of 45 to 75. And again, dietary things would be low red charred meats or processed meats, a diet high in fruits, veggies, whole grains, and possibly vitamin D. My recommendation would be colonoscopy. I think that's the best way for prevention of or early detection, actually, of colon cancer if you're going to screen. But again, whatever a person will agree to, such as if they will only do a FIT test, then that would be the thing we would accept. So I encourage everybody to be screened.
All right, Doc, that was great. Listen, we're going to go right to the question. Are you ready?
I'm ready.
All right, here we go. So we're going to start off with some compliments, and it get harder as we go along. Maria Torne say, all things are possible. Do you know this gentleman? Michael A. Townsend is watching. All right, here we go.
I've met him before.
All right. And then good information. My father passed away from colon cancer. Sorry about that.
Sorry.
Then we have Minerva Garden. Miss Garden says, is colon guard accurate screening, Doc?
So looking at the data that I looked at, supposedly they basically extrapolated the information. They didn't actually do a head-to-head to see whether it actually reduced the risk of mortality from colorectal cancer. But looking at the way in which other similar tests have been effective, they feel that it's somewhere in the 90% range effective for screening.
Dr. Danixa Gordon, what are your thoughts about using Metamucil, beneficial colon cleanse, and magnesium citrus for colon health?
So I think that using fiber supplements such as Metamucil, Ben fiber, those things, even on a daily basis, are as wonderful for adding fiber to the diet and keeping your bowels going. I think that there's wonderful. Be sure you drink lots of water with it. Because if you don't, the Metamucil can kind of do the opposite for you. So you want to be sure that you're having lots of fluid when you take that. Now, in terms of other colon cleanse, laxatives, magnesium citrate particularly is very, very strong. I would, and sometimes laxatives are needed and stool softeners, but I would minimize the use of them, because if you use them too frequently, you decrease the ability of the colon to do what it's supposed to do on its own. It becomes lazy, so to speak, and it won't work on its own. We've actually seen the evidence of people who've used too many laxatives. They actually get black pigmentation stains inside their colon from using laxatives too much. So I think when you need to use it, that's fine. If you want to cleanse your colon periodically, by periodically, I'd say a couple times a year to do a full colon cleanse. But just try to do it with more natural things like eating good, healthy food, Metamucil fiber supplements, and Ben fiber would be fine.
And here we go. Maria Torne, thanks for the awesome information, Doc. We're going to some other question here. Are you ready to roll still?
I am.
Here we go. It says, here's one. What role does supplements play in preventing colorectal cancer?
So let's see. Back in one of the slides, I talked about how there are some supplements. And so there are people who so it's kind of conflicting. Some data says, yes, please use vitamin D and magnesium and calcium and B6. There's folic acids in some studies have suggested, but there's conflicting data again. So If you're one who likes to take supplements, I think that probably taking them in moderation is probably not harmful, might be beneficial. In terms of some other kinds of food substances, I found some other things that I thought were kind of interesting. So things that are just good health otherwise would be things like garlic. Tofu can be helpful, berries, leafy green vegetables, olive oils, and selenium containing foods such as onions, fish, particularly salmon, halibut, tuna, nuts, and whole grains. I would say some studies suggest mushrooms. Some people have problems with mushrooms, but some people think that they can be helpful as well too. So feel that these things can have lots of antioxidants in it and some other things that can inhibit the growth of cancer cells.
Yeah. Here we go, Doc. Does the environment play a role in the development of colorectal cancer?
So I don't think that the data looks particularly at environment as such, but I think that there probably are environmental agents, there are toxins in our environment. And if you think about things like stress, I think stress can play a role in creating all kinds of disease for us because stress can suppress our immune system and plays a role in allowing cancer, keeps our immune system from surveillance and killing early cancer cells. So there's not specific data that says, yes, this particular environment or that one causes colon cancer as such, but I think that there probably could be some effects from environment.
So, Doc, I think you mentioned this. What are the early signs of colorectal cancer? We did that, right?
Mm-hmm.
Yeah.
I can answer it again.
All right.
So
Okay.
early signs would be things like blood in the stool, alterations in your bowel habits like diarrhea, constipation, can be abdominal pain, can be the diagnosis of anemia. Those are particularly the early signs, but you can have feelings of fullness, weight loss, unintentioned, those kind of symptoms.
So let's go back to this one, Doc. What criteria are used for diagnosis colorectal? You said the gold standard is colonoscopy.
Correct.
My question to you, and you said they drop it to age 45, right?
Mm-hmm.
Now, in preparing for a colonoscopy, it's I'm going to ask you. I see a question down on the bottom about beside what the doctor gave you, outside preparation. All right. So so let's go with this, Doc. Let's see. Here we go. Environment. No. We got that. Here we go. We got that. All right. This one. What it says here. I can't see my screen too good, Doctor.
Well, it says, what is the process to
Yes.
getting treatment?
Yes.
Well, if you're diagnosed with colorectal cancer, so hopefully, I mean, usually your doctor would have been the one to diagnose it. So they ought to be the one to help you figure out how to get to treatment. So typically, there will be several people involved in your care. One will be a medical oncologist. So besides your primary care provider, and I use provider because a lot of people are, besides seeing medical doctors, also see nurse practitioners or physician's assistants as well too as their primary providers. So your primary provider will refer you to a medical oncologist who will direct your care. But often, particularly if you're going to need surgery, you'll probably see what's called a surgical oncologist, the people who specialize in resecting the colon for getting rid of the colon cancer. If it's rectal cancer and they decide that you need radiation, they would also refer you to what's called a radiation oncologist. So those would be the ones who would direct your care in terms of how you get treatment.
Doc, while that process is also, I want you to think about at the end of this, if there's any, let's say I don't have any medical insurance, how do I go about this? But here's another question right there. Does blueberries, blackberries help prevent colorectal cancer?
So there are people who believe that they do, that they are helpful for that, probably because they have a lot of antioxidants. Now, some of the data says it's conflicting. Oh, antioxidants have not been shown to be helpful. But, personally, I think anything that's an antioxidant cannot hurt you and certainly can help in terms of decreasing free radicals, which play a role in causing all kinds of cancers. And certainly blueberries and blackberries, because they do contain a lot of fiber, can also be helpful in helping you as part of a good diet in prevention of colorectal cancer.
No, Doc, here's a question. Have you ever seen this? The Keto Flex 1, 2, 3 diet?
I have not.
All right, here we go. Here's another. What is the colon? You covered that already. All right, here we go.
So when people say bowel, it just depends on what they mean. They can mean also the small intestine and the large intestine. So the large intestines and the colon would be synonymous. The bowel could mean large and small intestines combined. So I would use bowel maybe to mean all of that, and colon with large intestines would
Okay,
be the same.
all right, here we go. I think you responded to this diet. Yes, right.
Yes. Yeah.
And then here's another one. Does drinking water affect the colon, and how much should a person drink per day?
So I think drinking water does, because from the standpoint of it helps to keep you from being constipated, and a prevention of constipation helps to keep those toxins moving through your colon, so they have less opportunity to sit in and affect your colon lining. So yes, water is helpful from that standpoint. How much should a person drink per day? Well, that's probably debatable a little bit too. However, the U.S. Academy of I think it's engineering, science, and I think it's mathematics, I'm not sure of the other, but they have determined that probably their recommendations are that for men, they should drink about 3.7 liters of water per day, and that women should drink about 2.7 liters of water per day. So I did the math. And if you turn liters into ounces, which is something that I think in the US we're more familiar with that
Yes.
system of measure. So that's something like for men about 122 ounces a day, and for women about 90 some ounces a day. And they say that we can get some of our fluid from food, about 20%. So if you subtract 20% from that, that would put men needing to drink about 90 ounces of fluid, and women somewhere in the neighborhood of about 70 ounces of fluid per day. Now that's kind of their recommendation, but it varies depending on other issues, like do you have congestive heart failure and other issues, kidney problems where you're told not to drink as much fluid. Some people don't need as much. They might get more from their diet. So one good rule of thumb is to look at your urine. If your urine is clear, like water, or light yellow, then you're probably getting enough water. If your urine is not, then you're not getting enough water.
All right, here we go. Doc, we're going to spend some time on this one because I
Okay.
have a question now.
I was expecting this from you.
The preamble to this question is: fasting any help in all of this discussion in the context of what you're talking about? Then the question.
So, in terms of fasting, there's some data to suggest that fasting, or at least like intermittent fasting and fasting, can be helpful, and has been used in some segments for treatment of cancer, actually. Mainstream medicine probably doesn't say you should fast as such, but there is some data that fasting may be somewhat helpful in the treatment of cancer. Yeah. So now, do you want me to answer this other question about colonics?
Please do. Go ahead, Doc.
So, again, the benefit to colonics, as I understand them, is that basically, I mean, you're cleaning your colon, and so you are getting rid of toxins, and so from that standpoint, can help to prevent colorectal cancer and colon health. I just personally think that colonics are probably needed infrequently. A lot of times people say that, oh, you have a lot of stuff lining your colon wall, but when I have looked inside colons, after a good colonoscopy, they are squeaky clean with nice pink lining, and there's nothing caking them. So if you are keeping your stool moving, probably don't need to wash your colon that often, but I think that probably doing it periodically is not harmful and probably helpful.
No, Doc. What happened if I'm scheduled for a colonoscopy? Could colonics help along with the medication that is given, the drink that you talked about?
Yeah, I mean, from the standpoint that yes, it can for sure make sure that you're good and clean. So the problem is that with some people, even with drinking the 4 liter of Go Lightly, they
Yeah.
still are not clean. And if you are not adequately cleaned, then it's difficult to have a good colonoscopy. Remember I said that about how sensitive they can be and
Yes.
how they're better for finding left-sided colon than right-sided colon lesions. And part of that can be if the prep is not perfect. So remember that they're actually looking at the colon lining. So if you've got little pieces of stool lining your colon, then they could miss a polyp hiding underneath that stool. Sometimes polyps can hide in the folds in the colon, because the colon does have folds in it, can
Mm-hmm.
hide behind folds and in bins and things like that. And so sometimes they're not seen. So yes, having your colon as clean as possible when you go for a colonoscopy is beneficial.
All right, here we go. Check this one out. Does detoxification good for your colon?
I'm not 100% certain what they mean by detoxification.
I think
Did
what they mean.
they mean colon cleanse, or I'm not quite sure what they mean.
What if we talk about it in terms of a purge?
Do you mean purge like and coming up the other way, as in and vomiting
No,
purge,
no,
or
the other way. The other way.
like so doing a colon like a colonic or enemas
Yes,
or something like
yes,
that?
yes. Enema, more
Um,
like the enema.
Mhm. So again, I think that those things are helpful for keeping you from being constipated. Again, I would not do enemas too frequently, because that keeps your colon from doing what it needs to do. It makes your colon lazy if you rely too heavily on laxatives and enemas. Though I think periodically they are needed, but I would try to not use them. I would try not to depend upon them.
Here's one. Doc, listen, how many bowel movement per day should a person have? Now, you touch on this. Some people say women have less bowel movement. Some people say 2 a week is good. What are your experience?
So I think what's normal probably, and normal, I use that word in with air quotes, because normal is going to be a little different from person to person. But typically, some people might have 3 form stools per day, and that's normal. Typically, we'd say 1 a day is probably what's good. Some people might not have one for 3 days, and for them that could be normal as well too. And so usually constipation is if you have less than 3 in a week's time. That's what's considered constipation. So it does vary a little bit from person to person, but I would say generally at least 1 a day. Some people can have up to 3 a day and still be normal, and some have maybe one every other day or every third day and still be normal.
Does it
But
make a
probably
difference?
what's best is once a day, I think.
Does it make a difference whether you're male or female?
I know that transit time through the colon is slower for women. Whether they have less bowel movements than men, that I'm not clear on, but I know that transit time is slower for women.
Here we go. Look at this one.
Lack of good colon health affect breath. Mm, not that I'm aware of in terms of colon health. There can be some issues in the stomach that sometimes can affect breath, but I'm not sure about colon health.
What about this one? Here's a question regarding herbs. Are we consider supplements the same as herbs? Some people do. Are they?
I don't consider that well, I don't consider it quite the same myself. When I think of supplements, I think of the things we take, like vitamins, minerals, things like that. And I think of, though herbs can be supplements, I guess. And so I guess they could be the same depending on how you use them, if you're taking them in pill form versus taking them fresh. So some of the herbs that we talked about, garlic is one that can be good for your colon. Um, that's pretty much the one that I'm aware of that can be good for colon. I'm not aware of other herbs particularly that can be good for other foods things, some selenium based foods, but and even olive oil, like particularly in a Mediterranean diet, they looked at that and thought that
Mhm.
that could be good for colon health.
Listen to this, Doc. You touch on this, but the last part is, or at least the rectum and the anus. Is it the same, all of this?
So no, the rectum is actually a little different. The rectum is the lowest part that goes down to the anus itself. So the anus is right near the end. That's right where it has the sphincter or the control. So when you need to hold your stool, then the anus plays a role in that. It has two sphincters, one internal and external. The external is the one you can see, the internal you can't see, but that they play a role in helping you to either retain or expel the feces.
Doc, here is one of we're coming up to the end of it. What is that?
So an anal fissure is on the outside, the fissure from the outside that you can see sometimes gets like a little split or a laceration or a cut in it. What causes it, again, can be a number of things. So sometimes inflammatory bowel disease, like we talked about, Crohn's can cause it, or ulcerative colitis can cause it. Sometimes if one has constipation and they're trying to expel a very, very hard stool, they can get a fissure from that as well too.
All right, we got two, a follow-up, and then the other one is the last one. Here we go.
Okay.
Number one.
So hemorrhoid, doesn't really affect the colon. Hemorrhoid, think of it as sort of a varicose vein, basically, down around the rectum and the anus, basically. So it doesn't affect the colon, but they can be painful. They can bleed. Yeah.
All right. And then this one seemed like the same, but there's some addition to it.
Okay, so hemorrhoids. So again, enlarged blood vessel in the rectum, anus area. Some are internal, where you can't see them, and some are external, where you can obviously see them. They can cause pain. They can bleed. What are they caused by? Constipation, having to strain too much, can cause hemorrhoids. Sometimes in childbirth, women will develop hemorrhoids from straining. So straining causes it. You can see that also in people who have liver disease, because it affects some of their blood vessels and enlarges some of their blood vessels. The symptom of it is generally pain. Sometimes they get thrombose, which means a blood vessel in them. Sometimes they bleed. And the treatment for them, depending on where they are. So external things like preparation H, Tux, things like that can be used to kind of shrink it. There are some other hemorrhoidal creams that can be used. If they don't respond to that and they cause too much problem with bleeding or pain, they can be surgically treated or banded.
All right. So Doc, if you have a few more minutes, we have like some questions coming in on Facebook. Okay. I wanted to see them. Can you see that one?
Mm-hmm. Yes, fish is helpful, and that is the reason, because it relates to omega-3s. So there are people who say, well, can I get omega-3 from flaxseed? So yes, that's possible. But when you use flaxseed, you have to remember that flaxseed can be a little bio-unavailable unless you process it properly. So like crushing it makes flaxseed more bioavailable than just taking the whole flaxseed.
Here we go. Another one right there.
There it is. Would flaxseeds be helpful?
All right, here we go. And then this one from Ty.
Fiber, yes. Fiber flaxseed meal. Okay, regularly. Yeah, I can see that.
All right, what about this one?
Well, okay.
I'm sorry, you want me to go back?
No, that's fine. That's fine. Yeah. Thank you.
Yeah, I'm just giving you them.
Okay, so again, colonics and preventing colon cancer. I think anything that keeps you from being constipated is good. I don't have a specific number on how often you should use colonics, but I think a couple of times a year would probably be fine.
All right, here we go. Sister Addie Green, thank you for sharing.
Thank you.
All right, Keith Tut.
I don't think so. I'm not aware that they're a problem for the colon. I mean, some people from the stomach, may have problems. They have burning in their stomach. And I know sometimes people will say that their stool comes out feeling hot when they have taken really hot peppers. But I am not aware that that's actually a problem.
Let me just clarify. Not a problem from eating hot food.
Right.
Right?
All right. From my perspective, yeah, right.
Okay, good. So guess what? We got through all of this stuff.
Yay!
I love it. I love it. Hey, Doc, just on a personal note, you look like Dr. Jackson. Are you familiar with that gentleman?
Would his first name be Craig?
Yes, his first name is Craig Jackson.
I've known him for a while, too.
Oh, you've been awesome. Thank you very much for sharing your information. I mean, we went along with a lot of questions, but you were right there. Really appreciate it. Tell Dominique, welcome back, and she was helpful at the beginning. Michael for logging in, and the rest of the girls, we really appreciate it. Awesome, awesome information. Dr. Jenkins, are you there? Let me see where Dr. Jenkins is. Here he is, where he is. Dr. Jenkins.